The cardiac surgery team here at St. Michael Hospital in Toronto is the first one in a GTA, in some cases in Ontario and in Canada, to be able to perform very innovative, groundbreaking surgeries here at St. Michael's Hospital. We have the pleasure of a chat with the person who made all of this possible, Italian doctor and associate professor with the University of Toronto, Gianluigi Bisleri. Welcome, benvenuto.
Thank you very much, Antonio. It's a real pleasure being here.
Dr. Bisleri, you are a cardiac surgeon, and your education and training happened in Italy. Can you tell us something about this?
Yeah, I was born and raised and trained in Italy, in the north of Italy, at University of Brescia. And then I had the opportunity to complete my training in cardiac surgery at University of Padua, where actually many important pioneering operations and procedures have been performed in cardiac surgery. And once my training was completed, I actually had my training abroad, and that covered in part in the United States. I did a research fellowship at Columbia University in New York, and once my training then was finished, I also did a clinical fellowship in the UK, in the Essex Cardiothoracic Center.
And then in 2016, you came to Canada with your family, a new chapter in your professional life and personal life.
Absolutely. It was definitely a very new experience for me. I had the opportunity previously to come and visit Canada, but never really experience Canada as a person living here and working here. And I have to say, it was, in a sense, a very smooth transition. We really immediately settled in this new country that really welcomed us. And initially, it was just my wife, myself, and our two dogs, everybody who came from Italy. And then we welcomed the birth of our daughter, who's now 3, and she was born here. We initially relocated to Kingston since I was recruited at Queen's University, and a year and a half ago, I was then recruited here at St. Michael's and University of Toronto.
So let's talk about these groundbreaking surgeries and procedures that you are able to perform, thanks, of course, to St. Michael's Hospital. Very important, delicate conditions, like, for example, conditions which affects the regularity of our heartbeat, or, for example, our mitral valve. Can you tell us something? Can you introduce somehow these procedures to the public?
Yeah, absolutely. So for me, it was a real, privilege having the opportunity to join St. Michael's that has been pioneering several procedures in the, cardiac landscape, so managing heart diseases. However, something that was actually not done before was a series of procedures that are still surgical procedures, but done in an extremely less invasive way. That's why this is called minimal invasive cardiac surgery. This is something that I had the opportunity to grow over time when I was still back in Italy, and we had one of the most active programs in Europe from that standpoint. So I actually brought that kind of expertise to Canada, initially at Queen's University, but the possibility for me to join St. Michael's was unique because given the environment that was so ready and interested in bringing this to a next level, that was exactly what I was hoping. Not only for my, honestly, professional career, but most importantly, in order to provide our population with something that wasn't very widely offered. So, as I mentioned, when I joined, I was able to add these minimal invasive cardiac surgical procedures to other procedures that are performed to treat heart diseases. As you were mentioning, there are different kind of heart conditions that we may face. And some of the most unique procedures we do are, for example, related to a condition of irregular heart rhythm, like atrial fibrillation, or to some valvular diseases, for example, mitral disease or aortic disease. If we want to start with the irregular heart rhythm, atrial fibrillation, it's a very common problem. If you think that roughly up to 2% of the general population can have this irregular heart rhythm, that's more like a sort of epidemic problem rather than a single disease in few people around. And when we look at people above the age of 65, it can reach up to roughly 8.5 10%. So it's really a huge part of the population which eventually is going to be affected with atrial fibrillation. Historically, atrial fibrillation, which is as I said, irregular heart rhythm, has been treated just by giving medications, which unfortunately are not very effective in many cases, or progressively other treatments like cardioversion, which means giving an electrical shock to kind of restore the electrical activity, has also been quite popular, but not very long lasting. So catheter ablation, so ablations using catheters, have been really the mainstay for many years, have been growing in popularity. But unfortunately, in certain patients, in certain conditions, catheter ablation, which works in general fairly well, is not successful. And that's exactly when surgery can provide, with these innovative treatments, a help to these patients. The main issues are related to the fact that the irregular heart rhythm, it's like a chaotic activity happening in the heart, especially in the upper chambers called the atrium. What we do when we do an ablation is that we create scars, so we burn certain areas of the heart in a way to almost create some fences that can basically direct the electrical activity in a very organized way around the heart.
How do you do that?
So we do by using specialized devices called ablation catheters that can burn the heart in very defined areas. So the cardiologists with whom I work with are typically burning from the inside of the heart. And we as surgeons are able to burn on the outside of the heart. And the uniqueness of what we are doing right now is that we can avoid opening the chest, we can avoid opening the heart or stopping the heart. We can do a surgical ablation on the outside of the heart, and we can basically help and work together with the cardiologist to complete what we have done from the inside when that type of ablation has failed. When we are treating patients with atrial fibrillation, we are performing an ablation, which means we are treating certain areas on the heart, on the top chamber of the heart. This is an example of the heart with the ventricles and the atria. And the atrial is the top part of the heart. And when we do an ablation, it means that we have to burn specific regions in the heart. What we are now able to offer is minimal invasive approaches that do not require to go inside the heart, but basically we are able to wrap around the heart in certain dedicated spots and areas these very innovative devices that allow us to be extremely effective without any need to open the heart or to open the chest. So the uniqueness is really to provide something which is really showing a very limited invasiveness, but a huge efficacy by combining something else done by our cardiology partners.
Of course. For a person like me, or I probably, I think I'm talking on behalf of many of our viewers, just to think about the fact that a doctor stops the heart to perform a procedure just is shocking. So I can only imagine. But these procedures need a particular device.
No, so I had the opportunity in my career. I was lucky enough that I actually had the opportunity to develop several instruments for minimal invasive procedures. In this case, I was collaborating with the company that basically developed these devices. So we were strong partners because it is new for Canada, but this is something I've been working on for the last 18 years. So it's something that has gone many iterations and many evolutions. And it's interesting what you're mentioning about the stopping the heart, which is for cardiac surgeons the easy part. Working on a beating heart is way more challenging.
I don't even want to think about it.
So that's exactly one of the important challenges that right now we are the only team in Canada offering this kind of procedure called hybrid ablation, which is, as I mentioned, a new way of combining these two techniques from cardiology and cardiac surgery. And we are constantly working in partnership with these industries in order to fine-tune and improve these devices and continuously improve the efficacy and reducing the complications.
You were talking about the actual incision, the actual cut. Can you compare the old cut, the length of the old cut that you used to have to do, compared to this new incision?
Absolutely. Well, I would say it's in a sense drastically different in the sense that the conventional incision is performed typically almost from like the jugular notch here to the xiphoid. So it's about easily a 20 centimeters incision on the front, which requires dividing the breastbone and obviously putting back together, which is for us as cardiac surgeons a very common and routine procedures, but it's extremely debilitating for patients. I personally found in my career, it's not only per se the actual incision, like physically how much it takes to heal, but psychologically, I found it's one of the long-lasting sign of trauma for patients that really sometimes the difficulty is to recover from that. So when we are performing conventional cardiac surgery, the incision is performed in the middle of the chest, so we call it sternotomy, and we divide the breastbone in the front. But when we are performing minimal invasive procedures, conversely, we do very tiny incisions on the side. Depending on the type of minimal invasive surgery, sometimes we make just 1 centimeter incision, like 3 of them on the right chest or on the left chest, or sometimes just below the chest. And when we do certain kind of procedures, for example, to treat the mitral valve, we perform the incision, which is typically a 3 centimeter incision between the ribs. This is very important. And this is a very nice way to understand that we don't cut any bone, but we are using dedicated instruments, and we are able to bring our instruments and to operate on the heart without actually putting our hands inside the chest of patients. And once we are able to be inside the chest, then we can actually work on the heart. And for example, for a valve, it means that the valve may have some problems in certain parts, and this is why operating on the mitral valve is so dedicated. It's because the valve has a lot of complexity that no prosthesis can actually reproduce completely, and this is why it's quite important the type of work we are doing on repairing mitral valves.
Dr. Bisleri, how did you fall in love with cardiac surgery?
Yeah, it's an interesting. It was an interesting experience for me. When I was in medical school, I was very much fascinated with the heart. I honestly at that time didn't really appreciate the difference between a cardiac surgeon or a cardiologist. And thanks to some friends, I had the opportunity to visit a cardiac surgical division and potentially start attending their department. And on my very first day, I was told, why don't you just go to the operating room? And I had never seen any kind of surgery, even less so open heart surgery. So you can imagine the shock. I was like, oh my God, maybe I'm going to faint. I don't know how I'm going to be reacting to seeing blood and an open chest. But when I went to the operating room and I saw the really, in a sense, the magic that we do by connecting the patient to the heart-lung machine, and also when we stop the heart and actually seeing the heart coming back and beating, it was something that even when I talk and mention that, it gives me still the goosebumps in a sense. And it was something that completely captured my complete drive and passion. And that really became not only something I was so much interested into, but truly a passion and in a sense a privilege to be part of that. If you think that these patients, compared to patients who receive a conventional incision, and in such case with a normal incision, we recommend patients to refrain from using their arms in like for heavy activities for about 6 to 8 weeks. When we're actually talking about this minimal invasive, they can return to a normal activity like a week before. A week after surgery, they can start regaining their normally activity, and that's very fast for them to, not having any kind of limitations in terms of weightlifting or whatever they need to do. So we are actually working not only the part on the part after discharge once patients go home, but we're working very intensively with my partners, my colleagues at St. Michael's, to actually have a journey also during the hospital stay so that can be shortened as much as possible, which means that the patients can receive the surgery, be very quickly woken up, extubated, and mobilized, and hopefully go home in a very, very short time frame, rather than the usual week that patients have to face once they undergo cardiac surgery. So that's important from different standpoints: patients' recovery, but also the resources that are required while in hospital for our system are going to be significantly impacted because patients can be discharged faster.
Of course. What are the other conditions that are serious, of course, and can be actually effectively treated with this groundbreaking surgery?
Yeah, so one of the other, let's say, conditions that we now treat quite frequently, to the point that we established this program last year, so in 2021, and in just above a year, we have become the largest program in Toronto and the GTA to treat mitral disease with a minimal invasive approach. And this is very important because we have a huge, again, number of patients with a problem called mitral valve regurgitation. So when people say that they have a leaky mitral valve, which means that the valve doesn't close properly. And number one, it's important to stress that every time a patient has a leaky mitral valve, the first thing that we would potentially aim for is to repair rather than replace, which means maintaining the patient's own valve rather than replacing with a prosthetic artificial valve. It's interesting that when I explain that to patients, very often I get asked by patients, why don't you directly put a new valve in? Because there's nothing so sophisticated as our own valve if it can work in a more effective way. So repairing a valve is actually not that obvious for everybody. It requires people with a special, dedicated interest from that standpoint. And I'm particularly happy that I basically brought, in addition to this, the minimal invasive approach, which was not offered in Toronto before. And now we grew so that, from the entire GTA, we have patients that are, coming and being referred for these kind of procedures, which again allows us to fix even complex issues with the valves, avoiding the incision in the front and just having a 3-centimeter incision on the side between the ribs. I have patients of different age ranges, but I can tell you that when I've operated young patients in their 40s or 50s, they've been telling me that they've been able to go back to their physical activity, going to the gym. Some patients even going back to doing push-ups a few weeks after surgery, which is, if you think about that, incredibly, gratifying for us to be able to offer a very effective type of surgery, and at the same time can allow patients to quickly return to normal lifestyle.
You mentioned the age difference, of course, but does age have an influence on the procedure? Like, do you have to take particularly care when you are performing the same surgery in different kind of people, patients?
No, that's a great question, and I think that this is one of the main important aspects of this kind of approach, is that we don't have per se any age selection. And the beauty is really that you can benefit the young patient or the elderly patient, maybe for different reasons. Let's say that if you have, for example, an elderly patient, it's normal for the bone to take longer to heal. And this is exactly where the huge advantage of having a small incision on the side between the ribs can be valued. You have a younger patient, they want to be more physically active, but they need to wait longer. And that's when, again, the minimal invasive approach allows them to return to a normal lifestyle faster. So really, we don't discriminate the selection of patients based on age. We have other factors, but now we have become more, let's say, open to like include more complex cases and a wider pool of patients being referred for these kind of procedures.
Of course, thanks to St. Michael's Hospital, this procedure is a reality here. What kind of future can you foresee for the procedure all over Canada?
Yes, first of all, I have to say that one of the things to remember is that I'm here today, bringing this important innovation and sharing with you and the audience. But this is not a solo person work. This is a teamwork. So I'm just here as maybe representing what, as a wonderful team we have here at St. Michael's, and the support I've received at every level, from my surgical colleagues to my other partners, cardiology, the team in the OR, anesthesia, nursing, perfusionist. This is not like a tennis player winning a championship by yourself. This is more like when the Raptors won the championship. So it's just because you have a team supporting all together. And this is something that I think it's key, that sometimes the misconception is that you just need a surgeon with some technical skills and maybe the knowledge, but this is not going to become reality if you have the entire team supporting. So I think that this is an important example that hopefully will be reproduced to into other institutions. I'm very pleased to see that we're now starting to get also centers from Canada coming to learn about the minimal invasive mitral. And also, especially for the arrhythmia disorder, the atrial fibrillation we talk about, we are actually having already a few centers that are interested to come and join and learn how we do this, because as I said, this is really unique in the country.
Of course. Excuse my curiosity, but I'm very curious about a regular day in a surgeon's life. How do you spend your days?
We typically wake up very early, obviously, because often we have our meetings. We start on average like at 7 a.m. And then by the time you're finished, you normally quickly round on the previous day patients, and by 8:15 you're in the OR. You perform the procedures. Between cases, typically you see some patients. Maybe some new patients. You have also again to round on patients on the floor. Then you typically, we normally do for surgery 2 procedures per day. And then when the day is in the late afternoon, when the surgery is finished, then you also have, as you mentioned, we're also faculty at University of Toronto, so you also have to do some research activity. And hopefully you got some time for your family.
Of course. How many procedures in a week? 10, 12?
It depends. We are on average, for example, I do perform surgery, but also perform some transcatheter procedures in partnership with my cardiology colleagues. So, for example, many weeks I'm every day in the between the operating room and the cath lab.
Even more than 12?
Oh, it can be. Yes, it could be. Yeah.
So, excuse my crazy question at this point, but how do you keep your focus? I mean, every of course procedure is important than the others. So you need to keep your focus, your energy for each operation.
Yeah, no, that's very true. But this is exactly, I think, why we we are particularly into this, is that the drive that you put and the focus, it's something that you almost naturally develop, and you almost have your your zone where you enter, and that's sometimes the kind of time and environment that you enjoy a lot, because it's really when you can be fully committed to what you're doing, and it's almost like everything else around you fades away in a sense, and you're completely in the moment there. And I would say, in a sense, it becomes almost like an addictive habit that you have, where you actually really enjoy being as much as you can focus on taking care of that patient, and really time really disappears around you, so you don't even know if sometimes it's been 1 hour or 5 hours.
Of course. Dr. Bisleri, should our viewers be interested in knowing something more about these procedures, what can they do to be more informed?
Absolutely. They are more than welcome to reach out to my office, but I also have a website that is called minimalinvasiveheart.com, where they can find more information about the procedure we talk about and others, and also how to contact my office for more information. And I also have created some social media, resources. For example, there is a Facebook page where, we post this kind of information for patients.
Dr. Gianluigi Bisleri, all the best to you. Thank you for being with us.
Thank you very much for having me.